All right, let's carry on, shall we? Okay, question 11. The glomerular capillary filtration coefficient, or KF, is one of the factors determining glomerular filtration rate, or GFR. What is KF a product of? Is it arterial blood pressure and surface area and net filtration pressure, surface area and hydraulic conductivity and arterial blood pressure, or afferent arterial resistance and net filtration pressure? Okay, so as before, let's visualize this just to help us get a bit of a better understanding of it. Okay, so when you're trying to work out glomerular filtration coefficient, there's two factors you have to kind of take into consideration. So those two are the glomerular capillary surface area. So let's see if we can. Okay, so the glomerular capillary surface area, so that's SA. And this is the larger surface area available for filtration. So the larger it is, generally speaking, the higher the KF. This surface area refers to the total area of the glomerular capillaries available for filtration. If you kind of look at the diagram, you can see that in effect. You know, the larger surface area, the more room we're going to have for filtrate to pass through. It's the same kind of idea with you having alveoli in the lungs to increase surface area to increase the total amount that we have passing through. So this surface area, much like with alveoli, it's influenced by factors such as the number and the number and the size of each of these functioning glomeruli. And then the other one you're going to want to be thinking about is hydraulic conductivity. So hydraulic conductivity, it kind of represents like it's the permeability of the membrane to water. So it determines how easy water can move through the capillary walls. And this is influenced by like the structure and the integrity of like the membrane. So from that, we get the equation, which is one that's always handy to remember. So surface area times hydraulic conductivity leads to glomerular filtration coefficient. So if we scroll back up here, surface area and hydraulic conductivity is our correct answer. One thing I found that a lot of people kind of struggle with this and why they get it confused is because there's another equation quite related to nephrology, and I think sometimes people can get them mixed up, and it's really easy to do. So the other one that you'll sometimes be thinking about is what's known as net filtration pressure. So we're just going to put NFP there to stand for net filtration pressure. So the net filtration pressure considers all of the forces acting on the capillary bed. So this does include arterial blood pressure. That is a component. So so arterial blood pressure is a component of net filtration pressure. Neither blood pressure nor filtration pressure is involved in the glomerular filtration coefficient. So they're not related to this equation. So when, just to kind of talk through it, just so we can separate them out. So the net filtration pressure is calculated as the difference between the glomerular capillary hydrostatic pressure. So we'll write this as PG. So that stands for the pressure involved, as well as the sum of the osmotic pressure in the Bowman's capsule. And it's always, so this one is represented as this little pi sign. GC, as well as the hydrostatic pressure in the Bowman's capsule, so PB, and that gives us our equation for net filtration coefficient. So these two are separate. So this one, so net filtration pressure is equal to capillary hydrostatic pressure, and that is the sum of the pressure in the Bowman's capsule and the hydrostatic pressure in the Bowman's capsule. So try to get those two, those are two separate things. So if we go up here, we can see the other ones: arterial blood pressure, net filtration pressure, arterial blood pressure, net filtration pressure. So you have to try and remember those are two separate things. And with this one, it's basically just the odd one out, which are the ones that doesn't involve that. And I know a lot of these terminologies can be a little bit confusing. Sometimes they'll have like a lot of very similar sounding equations, and it's quite easy to mix them up. And they seem to know this, and they deliberately make questions designed to try and trick you up. So just try to be aware that those are two separate things: glomerular filtration and net filtration pressure. So when you're looking at it, look about, does it contain pressure in what the question's asking? If it contains pressure, then what it requires for that equation is going to have pressure in it. If it doesn't contain pressure, it doesn't have pressure. That's kind of how I remember it, if all of the other information has gone out of my head. Okay, so question 12. What is the primary role of osteoclasts? So is it bone alleviation? Just move this over. Bone healing, bone reabsorption, bone remodeling, or bone formation? So the way I like to remember this is that it's kind of the opposite of what you would expect. So blast to me means like explosion. So I think of it destroying bone, when in reality, osteoblasts form new bone tissue, whereas osteoclasts break down old tissue. And I've been doing questions with my friend, and a lot of time we have to start saying osteoblast, osteoclast out loud just to make sure we've got this round the right way. So these are the two really important cells involved in bone remodeling. So the way osteoclasts break down old tissue is through a process called bone resorption, and that's basically just our answer. It's osteoclasts, bone resorption, and osteoblasts are bone formation. So the way it does this, so osteoclasts secrete acids and enzymes. Let me move down here. Secrete acids and enzymes that dissolve the mineralized matrix of bone, and this then releases calcium and phosphate ions into the bloodstream. So this process of bone resorption does lead to bone remodeling, but bone remodeling describes the continuous resorption that occurs following the formation of bone, rather than the resorption alone. So it's more of a terminology question here. We wouldn't really use the term bone healing. I mean, I guess it kind of describes in layman's terms the process of remodeling, but that's just not a term we use. Bone formation, so this is osteoblasts rather than osteoclasts. So if it was asking what the primary role of osteoblasts is, yeah, fantastic, bone formation with this. And then bone alleviation, again, that's just not a term we use. So bone resorption. Okay. So, question 13. Which of the following is a protective factor regarding the development of osteomalacia? Is it low body fat percentage, vegan diet, Crohn's disease, darker skin, or pregnancy? So osteomalacia is a disease, and it's sometimes put in the same category as rickets, because they are very, very similar. And it's usually said that osteomalacia is rickets in adults and rickets is osteomalacia in children, so particularly before the ends of the bones are fused together. That's not entirely accurate, but it's a little bit beyond what we want to go into. They are very similar diseases, and they do form this disruption in the bone. But we are a little bit different. But we're not going to worry about rickets right now. We're just going to focus on osteomalacia. So osteomalacia is defined as osteopenia with disordered calcification, which lead to a higher proportion of osteoids. So these are unmineralized, mainly collagenous tissue, and osteomalacia occurs after epiphyseal closure. So when the ends of the bones have fused. Again, if it was occurring before then, it's usually more denoted as rickets. So osteomalacia leads to this softening of the bone, and this is typically due to vitamin D, calcium, or phosphate deficiency, although vitamin D is the most common. So the bone mineralization process is impaired, and this leads to bones that are weak, fragile, and prone to deformities, hence this kind of bow leg, like horse leg. What's the term for that? Bow-legged appearance. We'll just leave it at that. So yeah, the primary cause of this is deficiency in vitamin D. That plays a crucial role in calcium absorption and bone mineralization. So without adequate vitamin D, the body cannot effectively absorb calcium from the diet. This leads to low levels of calcium in the blood and the inadequate mineralization of the bone matrix. So knowing that this is mostly caused by vitamin D, we can start to logically work through our potential answers here. So pregnancy. Pregnancy is going to raise our vitamin D requirements. Obviously, we have another life form inside of us that's also going to need it. So this is going to increase our risk of developing osteomalacia because we're going to need more vitamin D in order for both of us to function. I say both of us like I'm ever going to get pregnant. You know what I mean. Darker skin. So the higher melanin content in darker skin reduces the body's ability to synthesize vitamin D from sunlight. So this is actually a risk factor of osteomalacia. And it's also why if you go back hundreds of years and you look at the demographic, it's why dark-skinned people tend to be in more hot regions because they needed it to protect them from the sunlight, whereas you get light-skinned individuals in more cold regions because there's less sunlight, so you need to try and absorb as much as you can. And that's kind of how that, on a geographical and I've completely forgotten the name of that entire band of study, but like on a geographical distribution, why that tends to occur. So Crohn's disease. So Crohn's disease is an inflammatory disease of the intestines, and if you get inflammation of the intestines, that's going to be interfering with absorption. So again, Crohn's disease is another risk factor. If you have Crohn's disease, it actually increases your risk of osteomalacia. And then vitamin D, naturally, if you're trying to get it through your diet, it's found in very high amounts in oily fish, red meat, liver, egg yolks, stuff like that. So having a vegan diet is going to make it harder to get levels of vitamin D. So again, this is not going to be a protective factor. So that just leaves us with low body fat percentage, which, and I've had this conversation with a few people, might actually seem counterintuitive at first, because one would think if someone has a larger fat store, then they would have higher levels of total nutrients in the body. And that's correct, but that's kind of the problem. So if you have a high body fat percentage, it creates a higher capacity for vitamin D to be stored in your body. And because the vitamin D is being stored in your fat, in your adipose tissue, it's therefore not circulating the body in the bloodstream. So having a lower body fat percentage is a protective factor for osteomalacia, and having a higher body fat percentage is a risk factor. Okay. Question 14. What is the most common type of spina bifida? Is it anencephaly, microcephaly, spina bifida occulta, meningocele, and myelomeningocele? Okay, so spina bifida, let's start with a diagram. There we go. So spina bifida is a congenital condition, so one that usually starts from birth, when the neural tube, which eventually develops into the spinal cord, fails to close completely during embryonic development. So this is an embryology question. So this incomplete closure leads to a range of spinal cord and spinal column abnormalities. So spina bifida occulta is the mildest and most common type. And that just is something that comes up in medicine quite a bit. Usually the less serious is the more common. The more serious is, well, more of the body has had to have something go wrong in order for that to occur. So spina bifida occulta is our correct answer. But we'll just talk through the other ones just to kind of get an understanding why and also what they are if you're not familiar. So in spina bifida occulta, we can see this diagram here, there is a small gap that occurs in one, sometimes more actually, of the vertebrates. So the spinal cord and it's covering the meninges, that remains inside the spinal canal, and that rarely protrudes through the resulting gap. Spina bifida occulta does not cause any symptoms, and it usually goes unnoticed unless it's discovered by accident during like imaging studies for unrelated reasons. So there's actually quite a lot of people out there that have this, completely unaware they have it. Doesn't cause a problem. In meningocele, you get this sac or cyst containing the meninges, and that protrudes through the opening in the vertebrae. Although usually there is no nerve damage, and we can see this in image 3 here, the nerves aren't actually moving through into that cyst. So you'll usually notice this as a lump on the back, and this is usually in the lower spine around the lumbar region. In fact, just to help visualize what it looks like, you would see this kind of lump. Okay, so yes, this occurs. It doesn't involve the nerves. So moving on from meningocele, you then get this myelomeningocele, and this is the most severe form of the condition. So in this case, both the meninges and a portion of the spinal cord protrude through the opening in the vertebra, and this one tends to lead to significant neurological deficits. So it can include paralysis, loss of sensation, bladder, bowel dysfunction, a lot of neurological complications like that. So these two are more severe forms, so we can rule those two out. But then it's like, okay, what the hell is anencephaly and microcephaly? And I think a good way to help try and visualize this, this is actually a really nice diagram for this. And this shows some of the different conditions you get based on where the neural tube defect is. So at the top here, when it's at the caudal end, you get anencephaly and inencephaly. You then get these other ones in the middle, which we're not going to cover just yet. And then spinal bifida, you can see here, is more at the tail end. So, in fact, let's get this one as well. This is another one to help doing it. So again, at this caudal end, this is when you get like open spina bifida and closed spina bifida. So two versions of it from the caudal end, and then at the head end, you end up with. Sorry, just get. Okay. You then end up with stuff like anencephaly. So anencephaly occurs when there is failure for the neural tube to close at this head end during the development, and as you can see, this leads to a major. I don't know why. I just realised I'm moving my mouse over it, and it's not actually coming up on the recording. Sorry. Okay, so this leads to a major portion of the brain, skull, and scalp not forming correctly. Babies usually have a significant portion of the brain missing, and as a result of this, most of them are stillborn, sadly. Only a few of them survive for a few hours or days. Usually the ones that last a few days is because there still is the brainstem present, so respiratory, being able to breathe, heart rate still going, but that's basically it. There isn't much there, and as you can imagine, it's quite traumatic for the poor mothers that have to go through that. And then the other one we have is microcephaly. And if you're, thinking of this, anencephaly, so absence of the top of the head, microcephaly refers to this, where you have kind of like this small head, basically. And this is a little bit different because microcephaly, you have the small head and the underdevelopment of the brain. It's not caused by a problem with a neural tube defect. So it's usually caused by things like the Zika virus. Genetic factors have been implicated, certain environmental factors as well. It itself is not a neural tube defect, but it can often be associated with a broader spectrum of developmental abnormalities. So that's actually not a neural tube defect. And also, neither of these are a form of spina bifida, so it's neither of those. Okay, question 15. Where is gonadotropin releasing hormone, or GnRH, produced in females? So is it in the adrenal cortex, the hypothalamus, the anterior pituitary gland, the ovaries, or the posterior pituitary gland? So this is a bit of a trick question with it saying produced in females, because gonadotropin releasing hormone is produced in the same place in females, in just to make you doubt yourself, really. So you need to have a lot of confidence with you. And I think the best way to understand this is to look at the HPO axis. Like, honestly, if you can just remember how the HPO axis works, like 50% of endocrine you've got down, pretty much. So the HPO axis is known as the hyperthalamic pituitary ovarian axis. And if we just kind of like work through this logically, so you have these arrows with a plus saying that that is a positive, why has my brain forgotten the word of it? Positive feedback loop. So in the case here, hypothalamus leads to gonadotropin releasing hormone, which has a positive effect on anterior pituitary, which leads to more production. Whereas when you see these lines ending in a stop with the negative, that's a negative feedback. So they're going to reduce the production. So we just go through all of this. So you have gonadotropin releasing hormone produced in the hypothalamus in the brain. And this then stimulates the anterior pituitary gland to release follicle stimulating hormone, or FSH, as well as luteinizing hormone. These hormones then travel to the ovaries, where FSH promotes the growth of ovarian follicles, estrogen production or estradiol, while LH, luteinizing hormone, triggers ovulation, and then later down the line the formation of the corpus luteum, which then produces progesterone and estrogen. So this is all involved in this feedback loop. In men, the LH and the FSH instead goes to the male testes and produces testosterone. And this is the HPO axis. This is how it all runs together through an endocrine way. So the fact that it's male or female doesn't matter. It's going to be produced in the hypothalamus in the brain in both cases. The adrenal cortex is not related at all to the HPO axis. The anterior and posterior pituitary gland is implicated, and they sometimes ask this. The anterior pituitary gland is the one that produces LH and FSH. The posterior produces prolactin and oxytocin. So just try and remember that, because they will ask you between anterior and pituitary, try and remember that. But that's not where releasing hormone is. Hypothalamus produces, I think, like 8 to 10 different hormones. All of them are called releasing hormones. There's going to be one now that isn't. As far as I'm aware, they're all releasing hormones. So if you think releasing hormone, think hypothalamus. So it's not going to be anterior pituitary gland, not going to be posterior pituitary gland, and it's not going to be the ovaries. So the correct answer for both men and women is the hypothalamus. Okay. And carrying on with the urogenitals. Question 16. Which type of cell does follicle stimulating hormone, FSH, act on in males? So we know it acts on the testes, but what cell specifically? So is it the granulosa cells, the Leydig cells, the myoid cells, the theca cells, or the Sertoli cells? So only 3 of these are found in men and 2 are found in women. So let's start with the women's ones first, so we can rule those out. So here we have an oocyte. So in the oocyte, you can see there's these granulosa cells, and they're found in the ovaries of females, and they perform an essential component of ovarian follicles. They play a key role in folliculogenesis, which is the process by which ovarian follicles develop and mature. So the granulosa cells are these ones around the outside of the oocyte, and they produce estrogen in response to stimulation by follicle stimulating hormone, FSH. The theca cells are in the even further one. So you have theca cells right around the outside, and then below the theca cells, on like the second layer, you have the granulosa cells. So theca cells are found again in ovarian follicles of females, and these are involved in the production of androgens. Androgens serve as the precursor, so the molecule beforehand, for estrogen. And the granulosa cells are stimulated by FSH. The theca cells are stimulated by LH, so by luteinizing hormone. So the 2 hormones produced by the anterior pituitary, they act on different ones. In fact, let me just type that out. Maybe that's a little bit easier. So FSH is granulosa cells, and then LH, I can't spell, okay, and then luteinizing hormone this is theca cells. Okay, so those are the 2 involved with females. So we can rule out theca cells, and we can rule out granulosa cells. That leaves us with Leydig, myoid, and Sertoli. So let's grab another diagram to help us through this. And in fact, we're actually going to need 2 for this. So let's grab the other one, and we'll just go through this. Okay, so Sertoli cells are also known as sustentacular cells, and these are found in the semiferrous tubules of the testes in men. So at the bottom of this diagram here, you can see those Sertoli cells. So these provide structural and nutritional support to developing sperm cells, so through the process of spermatogenesis, and they also play a crucial role in regulating spermatogenesis. And they do this by producing various growth factors, so hormones and other kind of like signaling molecules, that kind of thing. So Sertoli cells are the primary target for follicle stimulating hormone. So again, in the same way as it was with women, so Sertoli cells are FSH. So FSH stimulates these cells to support sperm development. And then also here you can see a little bit further up, the Leydig cells. So these are also known as interstitial cells, and these are found in the testes of male. So they produce testosterone in response to stimulation by luteinizing hormone. So Leydig cells respond to luteinizing hormone. So these end up then producing testosterone. So testosterone is, well, I think most of us know, development and maintenance of male reproductive tissue and secondary sexual characteristics. And the final one we have are these myoid cells that you can see around the outside here. So myoid cells are smooth muscle-like cells found in the walls of seminiferous tubules within the testes of men. So these contract and they help propel sperm and testicular fluid through the tubules during the process of sperm transport. So those do not react, as far as I'm aware at this stage of my education, to any kind of hormones. So if we just put those together, I've done them. That's going to. I need to do this. It's going to annoy me otherwise. H, Sertoli cells, and LH, Leydig cells. So females and males. And if you're making notes you go along with this will be a good one to jot down, because again it's just kind of which type of cell does follicle stimulating hormone act on in males? Well, it is the Sertoli cells. Okay. Okay, question 17. After 24 hours of labour, a 26-week gestation neonate is transferred to the neonatal intensive care unit after he was found peripherally cyanosed with subcostal recession. His oxygen saturations are 80% and he has a respiratory rate with intratracheal installation of an artificial compound. Which of the following is the most likely compound to be administered? Is it an amphiphilic phospholipid, an amphiphilic protein, a hydrophilic phospholipid, a hydrophilic protein, or a hydrophobic phospholipid? So let's just wrap our heads around some of the terminology here. So obviously hydrophobic proteins are ones which repel water. Hydrophilic proteins are ones that attract water. Amphiphilic proteins are ones which contain both hydrophilic and hydrophobic portions to them. And then phospholipids are a class of amphiphilic lipids which tend to form major structural components in biological membranes. Okay, so we have this premature neonate. And when one is born at 26 weeks of gestation, they often have underdeveloped lungs and they can experience respiratory distress syndrome, which is what they're going through, which is also sometimes referred to as hyaline membrane disease. So respiratory distress syndrome occurs due to a deficiency of pulmonary surfactant, a substance composed of phospholipids and proteins. So when we're talking about this, when you're producing a protein like this, what ends up happening is with a surfactant, you have this hydrophilic head and a hydrophobic tail, and then they form what's known here as this micelle. These micelles will cluster together, and this is like the structure of surfactant. So when you're talking about a phospholipid bilayer, so the phospholipid bilayer is referring to this long sheet where you have hydrophilic and hydrophobic, and then the amphiphilic part is this micelle structure that it forms. So surfactant, the main purpose of surfactant is to line the alveoli, which reduces surface tension, and that helps prevent alveoli collapse during expiration. So just to visualize, in fact, this is probably a little bit easier to understand, actually. It's probably a bit confusing. So a surfactant is a chemical that lowers surface tension. Each surfactant molecule, as I was saying, has a hydrophilic component and a hydrophobic component, and they form together these micelles, and some examples just in everyday life. You have like detergents, emulsifiers. I don't know if you ever had like sounds strange to say, you ever had like a soup from a restaurant and they haven't made it too well and you've got like this little oily bits on the top of the soup. Those are basically clusters of micelle. That's the emulsification, and it's this structure that's causing that. And in the case, and I guess I'll have to warn you now, give you 5 seconds, that some might find this picture a little bit distressing. I don't think it's too distressing, but some people have an aversion to medical. I mean, most of you, I imagine, are studying for this, but for those of you who are just kind of interested for whatever reason, instead of watching Netflix, 3, 2, 1. So this is the procedure where you'll have an LMA inserted and then you have the surfactant administered, and this will help a premature neonate, help them to breathe a little bit better. So why exactly, I mean, why do we need surfactant to breathe? What is that doing? And I think understanding this helps to understand it a little bit better. I know one of my friends works better if she knows what the hell it is rather than just remembering facts. So we'll go through this. So at the air-liquid interface within the alveoli, surface tension tends to cause liquid molecules to attract each other. And this leads to a tendency for the alveoli to collapse normally. So this surface tension is particularly strong in small alveoli. So the reason our body produces this surfactant is because it disrupts the cohesive forces between lipid molecules by forming a layer at the air-liquid interface. The hydrophobic tails of the surfactant molecules insert themselves into the air, while the hydrophilic heads remain in the alveolar lining fluid. So by having this arrangement, it reduces the surface tension at the air-liquid interface, which makes it easier for the alveoli to expand during inspiration and also prevents them from collapsing during expiration. So by reducing the surface tension, pulmonary surfactant helps to maintain the stability of alveoli throughout the respiratory cycle. And yeah, this is pretty important during exhalation, because the pressure inside the alveoli at that point is higher than the atmospheric pressure. So it prevents smaller alveoli from collapsing more than the large ones. Without surfactant, the alveoli would collapse and makes it very difficult to breathe, and that's what's happening. Sufficient surfactant, the alveoli are starting to collapse, they're not able to breathe, and that's why they've gone into respiratory distress. Unfortunately, we do have treatments for them, so I'm certain the baby in that image was well taken care of and went on to live a happy life. But all of this means, I mean, I've kind of talked at length with this, so it's amphiphilic phospholipid. It contains both a hydrophilic and hydrophobic head. It doesn't contain just one. And because it's a micelle, it's a collection of proteins, not just a single protein. So it's going to be a phospholipid because it's this collection. So hydrophobic, rule out. Hydrophilic, rule out. Hydrophilic, rule out. Single protein, rule out. So pulmonary surfactant is an amphiphilic phospholipid. And I hope I explained that well, because I know this gets a little bit bogged down with the concept sometimes. And again, if you have any questions, please leave a comment under this video, and I'll try to get back to it if there's anything that you're struggling with, and I'll do my best to get back to it. Okay, question 18. Okay, a 76-year-old woman has had several episodes of fainting when getting up from her chair. She has a prescription for bendroflumethiside, ramipril, and clopidogrel. I always call that clopidogrel. It's clopidogrel. What age-related physiological change accounts for these episodes? So is it high blood pressure, reduced baroreceptor reflex, reduced kidney function, reduced liver function, or raised plasma renin levels? So there's two diagrams I think will help with this, and I'm going to flick back and forth between them. Come on, you know you want to get big. That's what she said. I just made a "that's what she said" joke. I cringe. I die every time. Right, so as people age, the baroreceptor reflex, so you have these receptors in the aortic arch that is involved in the baroreceptor reflex. That helps your body know what the blood pressure is like and whether to increase it or decrease it. So it changes not just the blood pressure, it adjusts heart rate, blood vessel diameter. It adjusts it basically to stop your blood pressure from getting too low. If this response is weakened, either from there's a whole range of different areas that can affect, but either from just the signals not being as strong, or the stretch response not picking up as much, because your body is now not adjusting and raising your blood pressure when you need to, this results in orthostatic hypotension, so a drop in blood pressure. So in the case of Our Lady, she's gone to stand up and the body hasn't adjusted for that movement. And I think a lot of people sometimes get this, even young people. Sometimes you stand up too quickly, you have like this dizziness, like your head can go a bit weird, because your body hasn't reacted quick enough to the change required in the blood pressure. So that will lead to the dizziness, lightheadedness, and in older individuals, it can even lead to fainting because you suddenly don't have enough blood going to your brain. So the correct answer for this question would be the reduced baroreceptor reflex. But why isn't it the other ones? So for this, we're going to have to look at what is known as the RAS system. The renin-angiotensin-aldosterone system. And we'll just kind of talk through this. So she's taken a few medications. In fact, what was she taking? She was taking Ramapil, clopidogrel, and benzoyl So all of those are related to cardiology. So the medication she's taken could have contributed to orthostatic hypotension. So benzoyl specifically is a diuretic that can lower blood pressure. Ramapil is angiotensin converting enzyme, or an ACE inhibitor. That's usually used to treat hypertension. And clopidogrel is an antiplatelet medication that's used to prevent blood clots. So it's very possible that because she's on all of these medications, because previously she had high blood pressure, that has lowered her blood pressure and perhaps taken it a little bit too far. And with the reduced baroreceptor response, that's helped exacerbate this orthostatic hypertension. So that's something, I mean, a lot of doctors will do this when you're prescribing these kind of medications to a patient. You need to monitor it because we want to bring the blood pressure down. We don't want to bring it down too low. So of the other potential answers we have, so we have high blood pressure is one of the answers. So high blood pressure tends to be associated with things such as stroke, heart attack, kidney disease. You would expect low blood pressure to lead to fainting, not high blood pressure. So it's not going to be high blood pressure. Reduced kidney function can lead to electrolyte imbalances. Again, this can lead to orthostatic hypotension, but it would not be directly accounting for these changes. So it's not going to be reduced kidney function. The liver typically affects the metabolism and clearance of medication. So, that could have been playing a role in the medication she has. But again, it's not going to be directly influencing blood pressure regulations. So it's not going to be reduced liver function. And then the final one, so renin plays a role through, again, what we were just looking at here, the renin-angiotensin-aldosterone system. But this would lead to high blood pressure, not low blood pressure. So if you have a raised plasma renin level, that's going to increase your blood pressure, not the other way around. So it's not going to be raised plasma renin levels. Okay. Right, so question 19. A 26-year-old female and her partner attend the neonatal clinic to discuss the health of their newborn child. Not have the disease. Which of the following is correct when counselling the patient regarding the health of their newborn child? So the child has a 50% likelihood of inheriting the mitochondrial disease. The child will not inherit the mitochondrial disease as it is autosomal recessive. The child will inherit the mitochondrial disease. The child has a 25% likelihood of inheriting the mitochondrial disease, or the child has a 75% likelihood. I'm certain when I've read that, there's probably a few people that have instantly brushed out their Punnett squares, and we do not need to know them at all. Okay, so mitochondrial diseases, such as Leigh syndrome here, these are typically, in fact, almost, it's a medical anomaly when it isn't, inherited maternally. So this means that they're passed down from the mother to her children through the mitochondria present in the egg cells. Just make this, no, okay, we can't make it bigger. Okay, so since the mother in this case has Leigh syndrome, her mitochondrial DNA will likely carry the genetic mutation responsible for the disease. Therefore, any children that she bears is going to inherit that disease. So it's important to note that when you're talking with mitochondrial inheritance, it follows this maternal inheritance, so it's not governed by the typical rules of Mendelian genetics. So again, you don't need your Punnett square. So autosomal recessive, dominant inheritance doesn't play a role in mitochondria. Are at risk of inheriting the mitochondrial disease, while the offspring of an infected father are not at risk unless the father himself carries a mutation in his own mtDNA, which is much, much less common. And then whether or not it's passed on is related to the amount of mitochondrial DNA that is passed over. But in the context of this question, because the mother has it, the correct answer will be the fact that the child will inherit the mitochondrial disease. It passes through from a maternal line. So don't have to worry about any kind of likelihood probabilities. Doesn't matter to us. Okay, now the final one. Oh, where have I put you? Question 20. A 15-year-old boy is referred to the pediatric neurologist with ongoing poor voluntary movements and coordination. He explains that since childhood, he has been unable to walk in a straight line or pick up objects with his hands, and these symptoms are becoming worse. His past medical history includes hypertrophic obstructive cardiomyopathy, so that's when you get muscle growth in your heart, which makes it more difficult to pass blood through. And on examination, there is evidence of kyphoscoliosis, so this is when the spine starts to bend, gait ataxia, which is difficulties coordinating movement, and absent ankle jerks bilaterally, so both sides. What is the most likely diagnosis? Friedreich's ataxia, juvenile myoclonic epilepsy, ataxia telangiectasia, myotonic dystrophy, or vestibular schwannoma. So let's go through these diseases one at a time. So the first one we have is Friedreich's ataxia. So Friedreich's ataxia is a genetic disorder which leads to a reduced expression of this frataxin protein. It's characterized by a progressive difficulty with coordination and movement, and this typically occurs in childhood. So common symptoms of this is gait ataxia, so uncoordinated movement, and we can see in this diagram this person with a walking stick because they're not able to walk too well. A loss of coordination in the arms and hands, you can see the other hand is shaking. Muscle weakness, Absent reflexes such as ankle jerks, so you can see they're trying to tap him with the hammer, and that isn't working either. Scoliosis, so the spine is bending, and in some cases, cardiomyopathy. So that sounds an awful lot like what our poor 15-year-old boy is having, isn't it? So the correct answer to this is Friedreich's ataxia. But let's go through the other ones just so we can kind of rule out why it isn't the other ones. So juvenile myoclonic epilepsy. So this condition presents with myoclonic seizures, which, oh my god, that is so... Okay, I'll read this because it's not very clear. So myoclonic seizures is the non-rhythmic jerks which result from involuntary muscle twitching that normally targets the upper extremities. After an episode, patients may describe the perceived sensation as momentary electrical shocks. So yeah, the juvenile myoclonic seizures presents with this, so you get these brief muscle jerks, sometimes in the legs, usually in the arms. And while ataxia can be a symptom in some cases of epilepsy, so the uncoordinated movement, it's not a common feature, and everything else that we've got going on, we wouldn't be jumping to this as a diagnosis. So the next one we have is ataxia telangiectasia. So again, this is another genetic disorder, much like Friedreich's ataxia, which is characterized by progressive cerebellar ataxia. So yes, it causes uncoordinated movements. It also leads to immune deficiency and an increased risk of cancer. So from the vignette, we haven't had anything to suggest either of those. And ataxia is a prominent feature, but the other main hallmark after it's named after is these telangiectasias, which are these red spider-like veins on the skin. Patients with this tend to have increased susceptibility to infections, as you would expect from the immune system being dysregulated. There's no mention of anything like this. There's no mention of increased rates of infection. So again, we wouldn't be jumping to this as the diagnosis. So the next one we have is myotonic dystrophy. So this again is another genetic disorder. So it's characterized by muscle weakness, which it did mention in the vignette, and myotonia. So this is those prolonged muscle contractions. You get ptosis, that's the drooping of the eyelid, a drooping of the mouth, and you do get some weakness of the facial muscles. You get some wasting of the sternocleidomastoid mastoid muscles around the neck. And you also tend to get like kind of this balding appearance, hatchet faces. So that's due to the atrophy of the temporalis muscle. So the head shape starts to change as well. Again, involved in coordination difficulties, muscle weakness. But the other symptoms we have, out of all four of them so far, Friedreich's ataxia is still our best bet. So the final one we have is a vestibular schwannoma. So this is a benign tumor, so it's not cancerous, and that arises from the Schwann cells, which are found in the nerve of the vestibular nerve specifically, so the one that goes to your ear. With this, you tend to get sensorineural hearing loss, usually on one side, because you imagine it's affecting one ear. That's where the tumor is, so you're not going to get it on both sides most of the time. It can cause tinnitus. It can cause imbalance, which could potentially lead to the ataxia, which was mentioned earlier. So yeah, it can cause the gait disturbances, but again, all the other symptoms, it's not likely to be that. Absent ankle jerks, the heart condition. In fact, none of these other ones are implicated in hypertrophic obstructive cardiomyopathy. None of them are implicated in kyphoscoliosis. So we can safely say, basically, this is kind of, there are symptoms which all of these have, but with a question like this, it's like, okay, which is the better picture? And hence why they call them single best answers. Because these could be differentials if you're going full zebra, but try to think more, you know, horses are horses, which I know is weird because Frederick's ataxia I don't think is particularly common. In fact, yeah, it's 3 to 4 in 100,000. That's silly me saying that, but try to go for the diagnosis that fits the full picture. So for the case of our 15-year-old boy here, the most likely diagnosis would be Frederick's ataxia. And that's all from this one. I'll see you in the next one. Thank you very much for watching.